Hey everyone, welcome back to part 9 of our massive 150-part IPDRG masterclass right here on Decode Healthcare with Harshal. I'm absolutely thrilled to have you back in the classroom today. So, last time in part 8, you'll remember we untangled that really complex web of sepsis, severe sepsis, and septic shock guidelines. We learned exactly why it's so critical to sequence those underlying infections correctly. Well, today, we're shifting gears to another incredibly high-stakes area in inpatient coding: acute respiratory failure and mechanical ventilation. This is a real game-changer, guys. It's a topic that single-handedly drives major shifts in MSDRG grouping, and honestly, getting it right is absolutely essential for both accurate reimbursement and clinical documentation integrity. But hey, before we dive into all that, just a quick reminder for you all. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Your support is literally what allows us to keep building this comprehensive masterclass for the whole medical coding community. So thank you for that. All right, let's look at the agenda for today's explainer. We're going to cover 1. Clinical indicators, 2. ICD-10-CM diagnosis coding, 3. ICD-10 PCS procedure coding, 4. Calculating ventilation duration, 5. CPAP versus mechanical ventilation, and finally, 6. MSDRG coupling logic.
Let's jump right in with number 1, clinical indicators.
Now, as you know, accurate coding always starts with the raw data the physicians are looking at in the chart. So what exactly does acute respiratory failure look like on paper? Basically, you're on the hunt for a few specific clinical indicators that prove gas exchange is failing. First up, we've got hypoxia. You'll see this as an SpO2 of less than 80% or a PaO2 dropping below 60 millimeters of mercury. Next is hypercapnia, or respiratory acidosis, which is flagged by a PCO2 greater than 50 millimeters of mercury coupled with a blood pH of less than 7.3. You'll also want to watch out for physical signs, like a respiratory rate soaring over 35 breaths per minute, clear signs of acute respiratory distress, and, of course, if the patient requires emergency intubation.
But wait, here is the absolute golden rule of clinical documentation improvement, or CDI. You must confirm provider documentation. Even if you're staring right at a blood pH of 7.2 and an oxygen saturation of 78%, you can never, ever just assume respiratory failure. As coders, our job is to verify that those clinical indicators actually correlate with the physician's explicitly documented diagnosis. If the lab values are screaming failure, but the actual diagnosis is missing from the notes, that is your cue to query the provider. No explicit linkage, no code.
Moving on to part 2, ICD-10-CM diagnosis coding.
Okay, let's translate those clinical indicators we just talked about into our J96 category breakdown for respiratory failure. This brilliantly illustrates how we categorize things. If the provider simply writes down acute respiratory failure without specifying the exact type, you'll default to J96.00. But if they do specify the gas exchange issue, we can get much more granular. You'd use J96.01 for hypoxia and J96.02 for hypercapnia. Now, what if the patient has an existing condition? Like, say they have COPD, and they suffer an acute exacerbation that leads to failure. In that case, you're going to look at the acute on chronic codes, which range from J96.20 all the way to J96.22.
Now, sequencing. This is a spot where a lot of coders can get a bit tripped up. So when exactly is acute respiratory failure the principal diagnosis versus a secondary diagnosis? Well, it acts as the principal diagnosis when it's the primary reason occasioning the admission. Make sense, right? However, let's say a patient is admitted for severe pneumonia, and then they develop acute respiratory failure on day 2. In that scenario, the pneumonia is your principal diagnosis, and the acute respiratory failure becomes a secondary diagnosis. And here's the real kicker. As a secondary diagnosis, it acts as a major complication or comorbidity, an MCC, which, as we know, significantly drives up the DRG weight and the facility's reimbursement. Oh, and a quick special sequencing rule to keep in your back pocket. If both acute respiratory distress syndrome, or ARDS, and acute respiratory failure are documented, ARDS actually takes priority, and you don't code the respiratory failure separately.
All right, on to Section 3, ICD-10 PCS procedure coding.
So when a patient requires these life-saving interventions, how do we capture them? Mechanical ventilation is a very specific pathway in PCS. First, we start in Section 5, which is extracorporeal assistance and performance. From there, we move down to Body System A, representing physiological systems. And the most critical decision here is picking your root operation. Mechanical ventilation goes straight to root operation 1, which is performance. Why? Simply because mechanical ventilation is completely taking over the physiological function of breathing for that patient. It's not just helping out, it is literally performing the work for them.
Let's tackle number 4, calculating ventilation duration. I cannot stress this enough. Calculating the duration of ventilation is where coders constantly make costly mistakes. These errors lead to audit failures or major lost revenue. You absolutely have to define the start and stop boundaries for counting consecutive hours of mechanical ventilation. It's like a strict timer. The clock starts at the exact time of intubation, meaning the initiation of the mechanical ventilation, and the clock stops at the exact time of extubation, or whenever that mechanical ventilation is officially discontinued. You have to calculate these consecutive hours meticulously, usually by digging into the respiratory therapy notes or the anesthesia records.
Now, what's really interesting here is how those hours translate directly into your final PCS codes. You're looking at 3 main duration categories. If it's less than 24 consecutive hours, you assign 5A1955Z. If they fall in the 24 to 96 hour window, it's 5A1945Z. And if it's greater than 96 consecutive hours, you'll use 5A1935Z. Notice how that 7th character changes entirely based on the time. Oh, and one more thing, definitely don't forget this. You must separately code the endotracheal tube, or ET tube insertion. That specific procedure is found over in Section 0, Medical and Surgical, under code 0BH17EZ. Remember, the ventilation itself is the performance, but the tube insertion is the physical device placement. You need both.
Section 5, CPAP versus mechanical ventilation. As an inpatient coder, you are going to constantly see all sorts of respiratory support. The fundamental coding difference here boils down to merely assisting a function versus completely performing it. CPAP and BiPAP machines provide continuous or intermittent positive airway pressure, right? Meaning they support the patient's own breathing efforts. Because of that, they fall under root operation assistance, which is root operation 0. So, for example, a CPAP used for less than 24 hours would be coded as 5A09357. But mechanical ventilation, like we just discussed, completely takes over the work of breathing, so it belongs under root operation performance, which is root operation 1. Trust me, misclassifying these two is a guaranteed coding error, so keep that distinction crystal clear.
Finally, let's look at number 6, IPDRG coupling logic.
So what does this all mean for the revenue cycle? How do these diagnosis and procedure codes actually work together to determine the hospital's reimbursement? The crucial point here is understanding how these codes couple in the DRG grouper. When you have a principal diagnosis of, say, severe sepsis, and you couple it with an MCC like acute respiratory failure, your DRG weight naturally goes up. But when you add a procedure code for mechanical ventilation for greater than 96 hours, you trigger a massive shift. This specific combination pushes the whole case into incredibly high-weight, resource-intensive MSDRGs, like MSDRG 207 or 208, which are set aside for respiratory system diagnoses with ventilator support for greater than 96 hours. And really, this just accurately reflects the immense clinical resources that were required to keep that patient alive.
So to wrap this all up, your precision matters immensely. Matching the exact clinical indicators to the correct J96 diagnosis code, perfectly differentiating between assistance and performance, and calculating those ventilation hours down to the literal minute, that is exactly what makes you an expert inpatient coder. We've covered a ton of ground today, and I know you're eager for part 10. But before we go, I want you to ask yourself, in your next coding audit, could a single miscalculated hour of ventilation cost your facility a major MSDG shift? Think about it, a single hour. Anyway, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep practicing those guidelines, always query when you're in doubt, and I will see you all in the next masterclass.